Hi, my name is Euan Zhang. I'm a neuroradiologist at Hamilton General Hospital. I have the pleasure of presenting on brain trauma. I have a small startup, but it shouldn't affect the information presented here. The objectives of this talk are to discuss the CT and MRI and acute and chronic findings of traumatic intracranial injury. I'll discuss patterns of injury in the major compartments, and in the interest of time, I have excluded penetrating injury and blast injury. I'll start with epidural hemorrhage. It's hemorrhage between the inner table of the skull and outer layer of the dura. They're biconvex. They can cross suture lines. I learned in med school that they can't, but they can. So don't use suture lines to exclude epidural hemorrhage. They're commonly associated with skull fractures. They can be arterial or venous, and making this distinction can help our clinical colleagues. Same for signs of active bleeding, which I'll show some examples of. In terms of arterial or venous, the location of the hematoma is the most helpful feature. If the hematoma is not adjacent a venous sinus, it's most likely arterial. If it's adjacent a venous sinus, it's likely venous. Here are some minis. If we have an epidural hematoma in the lateral aspect of the middle cranial fossa, it's arterial and associated with, of course, a branch of the middle meningeal artery. If it's in the anterior aspect of the middle cranial fossa, it is venous and associated with injury to the sphenoparietal sinus. If it's in the vertex or the occipital region, they are also both venous and associated with injuries to the superior sagittal sinus and transverse sinus, respectively. This is what an active bleed looks like. It's called the swirl sign, but I don't like the name because I've never seen actual swirling. These look like just amorphous blobs of hypodensity in hyper-intense or hyperdense blood, which just represents unclotted blood. Here's a case from an outside institution. 31-year-old man presented to emerge after an MVC. We have a small epidural hematoma in the lateral aspect of the middle cranial fossa, so arterial. There's also a skull fracture. Unfortunately, these findings were missed and the patient was discharged. Now, arterial hematomas tend to expand, so the patient was brought back 10 hours after, unresponsive this time, with a much larger hematoma, and we can see multiple blobs of hypodense blood indicating active extravasation. We have significant mass effect, herniation, and Carnahan's notch. We have central herniation causing a direct hemorrhage. The patient required an emergent craniectomy for preservation of life. The patient did well postoperatively and had only a small ischemic infarct in the right parahippocampal gyrus from herniation. Not all epidurals expand. Here we have a 32-year-old man assaulted with a hammer. He has an epidural hematoma in the same location, so likely arterial. He was doing well clinically. They didn't need to intervene. They scanned him the next day, and there was no significant expansion of the hematoma, and the patient was well enough to leave AMA. This was earlier in the year, and the patient is still alive when I checked last week. On MRI, epidurals look like hemorrhage anywhere else. There's diffusion restriction, iso-intense signal on T1 weighted images, and hyperintense signal on T2 weighted images with a bit of peripheral hemosiderin. We may want to rule out venous injury if there is a venous epidural, especially if there's an overlying fracture. This case is negative. I think a CT venogram would have been better, being mindful of our MR time. There's also no need for post-GAD sequence. If it's done though, you should see smooth pachymeningeal enhancement adjacent to the hematoma. Don't mistake ruptured arachnoid cyst with epidural hemorrhage. There's a large component of simple CSF mixed with hemorrhage in ruptured arachnoid cysts. You'll never see epidurals looking like this. Now with subdural hemorrhage, they are actually formed within the innermost layer of the dura as opposed to between the dura and the arachnoid matter. So they actually should be called intradural hemorrhages technically. They are crescentic in shape and venous in origin, and there's a lot of overlap of imaging features in each age category. So the best we can do is give an approximate age best done by CT. This is a hyperdense subdural hematoma. These are acute, meaning hours to days. I like to give a depth of the subdural. Make sure to measure in the coronal plane perpendicular to the skull, and make sure not to use the axial plane, which overestimates the depth of the subdural. Here we have bilateral subdural hematomas, which are isodense to brain parenchyma. So these are subacute, which is a few days to a few weeks in age. Here we have a hypodense subdural hematoma. The vast majority of these are chronic, which are at least a few weeks old. However, patients with hemoglobinopathies can have acute subdural hemorrhages that are hypodense. On MRI, again, not reliable for age determination. There are varying degrees of signal intensity on T1 and T2 in each age category. You should see pachymeningeal enhancement, though, in most cases, if for whatever reason you did a post-GAT sequence. Now, be careful about this entity. The resident called this a subacute subdural hematoma. I can see why, except there is significant hyperostosis of the overlying calvarium. So this is an on-plaque meningioma, which can look exactly like subdural hematomas. In an acute traumatic setting, don't confuse these with chronic subdural hematomas. These are subdural hygromas, which are common in head injuries. They don't grow. They cause minimal mass effect, if any, and they usually don't cause any problems. Even though they're supposed to be simple CSF collections, they can exhibit non-suppression on flare. They're also associated with mild smooth pachymeningeal enhancement. Now, contusions. They are arguably lacerations due to distortion of the brain at impact, which injures the parenchymal vessels. They are superficial bleeds. They often have a coup contra coup bilateral asymmetric pattern in the frontal and temporal lobes, particularly along the floor of the anterior and middle cranial fossa due to the irregularity of the surface of the skull base. They are associated with vasogenic edema and infarct, usually progressing over the course of the first few days. Here's a typical example of contusions. We have a 20-year-old patient who had a seizure. There was a questionable history of a fall. The clinician needed to know if this hemorrhage was traumatic or spontaneous. We have multiple superficial foci of parenchymal hemorrhage in a bilateral symmetric distribution within the orbitofrontal cortices. We have a mild degree of surrounding vasogenic edema and infarction. These findings are classic for contusions. We also have a non-displaced right occipital fracture, so no question, traumatic injury. On MRI, we have typical features of hemorrhage in the affected regions. We have diffusion restriction, hyperintense signal on T2 with peripheral hemosiderin, and hyperintense signal on T1. It's hyperintense on T1 because it was acquired 1 to 2 weeks after the injury. The cause of the seizure remains unexplained. Here's an 80-year-old patient admitted for stroke. He fell in his hospital room unwitnessed. He was scanned the next day, which showed new bitemporal coup contra coup pattern of contusions and subarachnoid hemorrhage. Here and here. The hospitalist didn't know at the time that the patient fell, so they were unsure if these hemorrhages were traumatic or due to TPA. The radiologist unfortunately missed this skull fracture. They did an MRI, which was non-contributory, showing hemorrhage in the same locations we saw in CT. It was later discovered in the nursing notes that the patient actually fell and hit his head. Sometimes contusions can be severe, requiring craniectomy. This is a 51-year-old patient who hit his head in a squash game, probably against the wall. There are large right temporal and left frontal contusions. Unfortunately, he's now severely disabled. Chronically, we have encephalomalacia of the injured parenchyma. Don't call these ACA infarcts. They go beyond the lateral margin of the ACA territories. All right, diffuse axonal injuries. It's a misnomer because it's not diffuse. There's a movement towards calling these traumatic axonal injury. We all know they can be caused by MVCs, but we can also see them in sports injuries, falls, and non-accidental trauma. There are two mechanisms by which DAI causes damage. The primary pathway is called primary axonomy, which is mechanical shearing and stretching that severs axons. This actually causes a small amount of damage compared to secondary axonomy, which is a biochemical cascade that is set off by the primary axonomy. In the interest of time, just know that a bunch of biochemical stuff happens after the impact, which results in local destruction of the axon, and it happens within 1 to 6 hours after impact. Here's a depiction of primary and secondary axonomy. You have the primary axonomy that disrupts the cytoskeleton and the biochemical secondary axonomy that ensues shortly after. There's grading for DAI, but this does not correlate with clinical outcomes. There's no convincing evidence in the literature, and our clinicians have also noticed that there is no correlation. So they don't put much weight on grading. It's more helpful to them if we just describe the anatomy. On CT, we may not see much. The CT can be completely normal. If there are abnormalities, there will be small hemorrhages within the white matter tracts, mostly in gray white matter junctions. Here we have multiple small foci of hemorrhage within the subcortical white matter and gray white matter junction of the right superior frontal gyrus. You can also appreciate their parallel orientation to the white matter tracts on SAG. MRI is the modality of choice. So DAI shows up on FLAIR as ill-defined areas of hyperintense signal, which also exhibits restricted diffusion. We can see microhemorrhage along white matter tracts. They tend to be a mix of punctate and linear foci in a radial pattern. Here are 3 different patients with DAI. It's an ill-defined region on FLAIR. Here we have involvement of the corpus callosum exhibiting avid diffusion restriction. And then here on SWI, we have multiple punctate and linear foci of microhemorrhage in a radial pattern. I showed the patient's CT a few slides earlier. Not all DAI regions have microhemorrhage on SWI. This is the patient with DAI involving the corpus callosum from the last slide. We see again ill-defined hyperintense signal on FLAIR, of course avid diffusion restriction, and only a few foci of microhemorrhage. But there's all this signal abnormality that exhibits diffusion restriction. So this is predominantly non-hemorrhagic DAI, likely attributed to the biochemical pathway that I discussed earlier. DAI can have a typical appearance on SWI. There are a couple of mimickers though. This is fat embolism. There needs to be a long bone fracture. We have innumerable foci of susceptibility in a symmetric diffuse distribution. This is amyloid. We have numerous small round lobar microhemorrhages in a bilateral asymmetric distribution. The white matter and central regions are largely spared. Chronic evolution of DAI, we have volume loss and gliosis of the affected white matter, essentially encephalomalacia, and ex vacuo dilatation of the surrounding ventricles and sulci. All right, moving on to traumatic subarachnoid hemorrhage. Traumatic subarachnoid is easy when the history of trauma is clear. Sometimes, however, we are not provided history of trauma or the history is unclear, but we still need to be able to call traumatic subarachnoid hemorrhage in those cases. The characteristics of traumatic subarachnoid hemorrhage are peripheral location, so the convexity sulci, trace volume, if multiple, a coup contra coup pattern, and if we're lucky, other injuries. Here is a coup contra coup pattern. Pretty easy. Here's a 55-year-old patient with vertigo, nausea, and vomiting. He vomited 20 times, had a syncopal event, fell, and hit his head. We were only given the history of vertigo in this case. We see that there is trace subarachnoid hemorrhage in the right cingulate sulcus. This is the only abnormality. No other injuries are found. The location and trace volume are in keeping with a traumatic cause. But if no history of trauma is given, if I were reporting this, I would say if there is a history of trauma, this pattern of subarachnoid will be in keeping with trauma. If there is no history of trauma, we would need to do a CT angiogram to rule out a vascular cause and go from there. Instead of a CT angiogram, they did an MRI, which is not that helpful. It shows typical features of hemorrhage. If you're concerned about subarachnoid hemorrhage, you really need to do a CT angiogram to rule out aneurysm or vascular cause. These cases didn't present with trauma, but just to illustrate what too much hemorrhage and wrong location looks like. On the case on the right, there are numerous sulci containing subarachnoid hemorrhage. Almost all of the sulci in the right hemisphere are involved. Even with a history of trauma, I would want to see other injuries because this is too much subarachnoid hemorrhage to be an isolated finding in the setting of trauma. In this case, it turned out to be a ruptured aneurysm. In the case on the right, we have a moderate volume of subarachnoid hemorrhage in the basal cisterns. Now, a tiny trace amount of hemorrhage in the interpeduncular cistern is something that we see with traumatic injury, but this amount of hemorrhage, of course, is too much. And this turned out to be perimesencephalic hemorrhage. Last but not least, intraventricular hemorrhage. Isolated traumatic intraventricular hemorrhage is rare. Often we see it with other injuries. Acutely, we can also have non-communicating hydrocephalus from obstruction of the aqueduct or foramina. And we see this with a subarachnoid hemorrhage also. Chronically, we would see communicating hydrocephalus from blockage of the arachnoid villi. Here's a case of isolated traumatic intraventricular hemorrhage from a textbook. I've never seen one in real life. Here's a non-communicating hydrocephalus. This is our squash player from earlier. We see dilatation of the ventricular system, including the fourth ventricle. The aqueduct is patent, but we can't make out the foramina of Lischka or Magendie, which are likely obstructed. There's already a drain in place. Here's an example of communicating hydrocephalus post-traumatic injury. The aqueducts and foramina are patent, and you also shouldn't see features of normal pressure hydrocephalus. In summary, we discussed a lot of patterns of traumatic injury with epidural hemorrhage. Try to identify if it's arterial or venous. Use CT to approximate the age of subdural hematomas. Know the patterns of traumatic subarachnoid and subarachnoid hemorrhage and contusions in case the history is unclear. Look for skull fractures. DI grading does not correlate with clinical outcomes. Remember that traumatic injury is a cause of chronic communicating hydrocephalus. In general, CT is sufficient in the acute setting. MRI is often not necessary except for DAI. I'd like to thank the course organizers, my radiology colleagues, and my clinical colleagues. Thanks very much.